In this unit, we'll be looking at obstructive airway disorders. In other words, disorders of the ability to get air in and out of the body. So in the last unit, we were looking more at the lung parenchyma, so the tissue, lung tissue itself, and this will be more in the tubular organs, bronchioles, primarily allowing air in and out. This material is found in your pathophysiology textbook, Copstead, chapter 22, and the treatment drugs, the drug treatment, I should say, is found in your pharmacology textbook in chapter 76. So what are obstructive airway disorders? Well, they're disorders that affect the conducting airways. So in other words, the trachea, bronchi, bronchioles, those type of areas that are the conduit for air exchange with the environment and your body. And so this problem can actually be within the lumen itself, so things that are blocking the lumen, for example, increased secretions, whether they're inflammatory or mucus or a combination of the two. Could even be something like a chunk of food, obviously blocking, resisting. We could have problems with the airway wall. Uh, Typically, that would be a thickening and a reduction in the lumen diameter. For example, with bronchospasm, or it could be bronchospasms, where we have muscle contracting, decreasing the lumen diameter. So both of those would result in increased airway resistance. And it could also be in the supporting structures surrounding the airway, where we now have air collapse. And we have to remember that air comes into our body because of a negative pressure in the thoracic cavity compared to the environment. And that negative pressure can cause that airway collapse. So all the way from the large structures like the trachea, if we have tracheal ring problems, all the way down to the bronchiole, we can have collapse in those areas. We'll focus on just a couple of diseases in this unit. One will be asthma, so bronchial asthma, and the other will be our chronic obstructive pulmonary disease, COPD, which is made up of two different entities, chronic bronchitis and emphysema. So asthma is an inflammatory process in the bronchioles or in the lungs, and so we'll kind of put our knowledge of inflammation together with this. And what happens is we get inflammation, which results in obstruction of airflow into and out of the lungs. This is typically in patients, it's intermittent, it's not constant. And so when you have an asthma attack, if you would, you'll see the patients will experience tightness of their chest, difficulty in breathing, so dyspnea. They can cough. Wheezing is very common as the airflow becomes turbulent as it goes through our lungs. And these patients have what we call increased reactivity to stimuli. And so what's going to happen is we have inflammatory mediators that are going to be released from mast cells, eosinophils primarily, that cause smooth muscle sensitivity, or reactivity, perhaps I should say, would be more correct. And that means that small triggers that would normally not cause the smooth muscle to contract now results in contraction of the smooth muscles in that area. And so what are these triggers? What is it that triggers these asthma attacks and this contraction of the smooth muscle in the airway? We've got different types. One is what we call exogenous agents. And so these are things like exercise, air pollution, viruses, so infectious agents. So these are triggers of bronchiolar constriction. We can have allergens, which we'll call atopic type of agents, or extrinsic asthma, we're going to call that, where we have allergies that can trigger that, very common with pollens, like, for example, this time of year and into the fall. And then we can also have physiological chemicals. So histamine would be an example of an asthma trigger when released in those people. So as I alluded to earlier, we have both extrinsic and intrinsic asthma. The term atopy, A-T-O-P-Y, is another term for allergy. So if we see atopic asthma, we're really talking about allergic asthma. Or we can have intrinsic factors, which are non-atopic. And so this would be due to again, those exogenous agents that we're dealing with. And I didn't mention, exercise asthma, a very, very common one, particularly in cold, dry environments. You'll get that the air itself is triggering bronchoconstrictions as our breathing increases. So let's start by looking at extrinsic or atopic asthma. And this is a type 1 hypersensitivity. As if you remember from our hypersensitivity unit, a type 1 will be mediated by sensitized mast cells. So we'll have massive histamine release that occurs. And so patients that have extrinsic asthma have exposure to an extrinsic antigen, and then we have activity, I should say, sensitized mast cells that occur. So we have antibodies, again, that we'll put on here. So we get antibodies that are put on the mast cells, and when we're re-exposed to that antigen, the antibodies bind to that mast cells and start having release of histamine in that area. So what exactly happens? We have kind of different phases, if you would, that we see in these patients. So when exposed to that extrinsic allergen, we have activation of these local inflammatory cells. So we just talked about the sensitized mast cells that are going to be releasing the histamine and chemical mediators at that point. So and other cytokines as well. So we have histamine is going to be a big one released. We'll have prostaglandins that go in that area. We'll actually get leukotrienes. If you remember leukotrienes, we're going to actually call that the slow reacting substance of anaphylaxis. So leukotriene pattern. So we get both prostaglandin and leukotriene release in that cascade. And so we also have cytokines from T helper cells as well. So the Th2 helper T cells that will be in that area, kind of quarterbacking that immune reaction that's going on. And so because of this sensitivity, this inflammation that goes on in the immediate phase, the acute response, we have this infiltration with inflammatory cells that come in, which will stimulate actually these mucus production in that area. So now we'll start having mucus being excreted into the airway, again blocking airflow through that area. We'll get an increase in mucosal permeability. So that inflammatory response, an increase in permeability in that area, which allows more mast cells to be exposed to the antigen that's being breathed in and out of the body. And I already said increased mucus production, and then we get these hyper-responsive smooth muscles. And so this is actually the vagal nerve coming in, and so vagal efferent, if you remember, is a parasympathetic nerve, and so that will be releasing acetylcholine onto this muscle, and acetylcholine results in smooth muscle contraction mediated through the muscarinic receptors located in the bronchioles. And all of that comes together causing a bronchospasm. So not only do we have a bronchospasm, but we now have mucus sitting in that lumen as well. So it'll be blocking that airway and having a significant reduction in lumen diameter. Over the next few hours, about 4 to 12 hours, now we have what's called the late phase reaction in extrinsic asthma or atopic asthma. And this is again an inflammatory response that's going on. And so again, cytokines release more inflammatory cells. We start having epithelial injury. And so notice up here we start having these epithelial cells that are injured at this point. Again, it's a positive feedback now because that injury is going to promote more inflammation in that area. We get an increase in vascular permeability. I got circled over here. I forgot to mention that these inflammatory cells coming in. So now we have basophils, neutrophils, eosinophils. So more and more inflammatory cells are coming in to this region. And again, here we have our mast cell releasing more histamine. We get increase in vascular permeability going on, and so these inflammatory cells are able to leave the vasculature and enter into the lung area. And that results in actually edema. So we get a pulmonary edema that's occurring in that area as well. And finally, we've got an extreme responsive, hyper-responsive smooth muscles to our vagal nerve stimulation. So the acetylcholine mediated through muscarinic receptors is causing a significant reduction now. In fact, a life-threatening reduction in that lumen of the bronchiole. And so we're still plugged with mucus. We've got more contraction. We've got more inflammation, thickening of the wall. All of that is going on in this particular patient at this time. So in summary, we start out with an allergen, so we become sensitized. We sensitize, so it'd be IgE-mediated mast cell sensitivity. The mast cells are going to release their inflammatory mediators, so histamine, leukotrienes, prostaglandins, interleukins. And those will directly result in bronchospasm, but they also call in the cavalry, so we get infiltration of inflammatory cells. We get this inflammatory soup, if you remember the inflammatory soup that's going on, and interleukins play a large role in that, as well as other inflammatory mediators. I forgot leukotrienes up here, right? The slow reacting substance to anaphylaxis is being released in large numbers as well. And because of this now, so this would be the early phase at this point that's going on. In the late phase, we get just more airway inflammation, which results in the inflammatory response. So we have edema, we've got epithelial tissue injury, the mucociliary function is impaired, so we're not moving that mucus upstream anymore or orally, right, towards the oral cavity. So it just sits there and now it starts building up in that. In addition, we have increased mucus production, which I've added to the slide because it wasn't on there. That's going to be occurring at that point. So this leads to our airflow limitation because of that inflammatory swelling that's going on. We have increased airway responsiveness to our vagal tone, and so we get all of these result in bronchospasm. So it's a sequence of events that occur. It's basically an inflammatory response that's occurring, resulting in injury, mucociliary function impairment, edema, bronchospasms. I guess that would be the big one at that point. So looking at intrinsic or non-allergic or non-atopic asthma, the pathogenesis, pathophysiology is the same. In other words, those same things are going to occur in these patients that occurred in the allergic asthma patients, the extrinsic patients, but the triggers are going to be different. And so in this case, we have respiratory infections that can trigger that. So we get epithelial damage with IgE production due to that infection that's occurring. We can have exercise-induced asthma. And again, so it's very common in cold air or people that are hyperventilating. And that loss of heat and water can cause bronchospasms. I used to coach my daughter's hockey teams all the way up to high school. And that cold arena air was just terrible at inducing exercise asthma. And so my pockets in my coat on the bench, I would have 6 or 7, 8 inhalers in there for these athletes that were breathing that cold air and having these asthma attacks during a hockey game. Inhaled irritants, so tobacco smoke, pollutants, those types of things will cause inflammation and a vagal reflex as well. And then finally, our non-steroidal anti-inflammatories. So as we learned during that, that we can have, we need to be careful with asthma patients giving non-steroidal anti-inflammatories and aspirin because now we have an abnormal arachidonic acid metabolism. And so if we remember, our COX-1 synthesis synthesizes protective prostaglandins, and our COX-2 is the inflammatory mediators. And so if we take, if we block COX-1, it's going to shunt the arachidonic acid into the COX-2, leading to inflammation and bronchoconstriction. And so if we get off balance in that, we can have problems with triggering asthma attacks. So here's our arachidonic acid cascade again, which is talking about what we just mentioned. So we have our two pathways. So I'm going to back up way back to the beginning. So if we recall, and I did warn you, you'd see this diagram again. We have our cell membrane phospholipids. So the source of arachidonic acid is the cell wall itself. And so inflammation activates the phospholipase system. Which releases arachidonic acid from the phospholipid cell membrane. And then down this direction that I have circled is extremely important in our asthma pathway. So both the cyclooxygenase and 5-lipoxygenase pathways are important, but this one is extremely important. And so down here we have that leukotriene synthesis. Okay, leukotriene synthesis. And if we notice over here, bronchospasm is a significant effect of leukotrienes. And so all of these things, vasoconstriction, bronchospasm, and increased vascular permeability, we'll see as contributing to our asthma attack. And up here is chemotaxis. So we're calling in the cavalry, we're calling in inflammatory cells. And so the lipoxygenase pathway is very important in mediating this, in addition to the prostaglandin pathway, but this one is more important, if you would. And so we'll see. Remember, that's a slow reacting substance to anaphylaxis, is this leukotriene pathway that we have going down. Now, looking over at the cyclooxygenase pathway, so if you remember from our unit, PGE2 is going to cause pain and fever and those types of things for inflammation, so it's a big mediator for that. But let's look at PGD2. PGD2 is going to be also important for bronchoconstriction, and so these are released from mast cells, and so PGD2 also contributes to this effect of bronchoconstriction due to that inflammatory response or the arachidonic acid cascade. So moving to our next topic, chronic obstructive pulmonary disorders. So COPD, or chronic obstructive pulmonary disease, is sometimes what it's called. And this is, it's better to say disorders, because this is really a group of respiratory diseases that are characterized by two different pathologies, if you would. One is chronic bronchitis, and the other is emphysema, and both of those result in airway obstruction. So the obstruction is a progressive thing, and it's also accompanied by bronchiolar hyperresponsiveness, just like we saw in asthma. So we're going to see treatment of asthma and COPD are going to be very, very similar because of that hyperresponsiveness of the airway that we're seeing in both of these obstructive disorders. This one is by far, well, I should say the most common etiology by far is smoking. So we'll see this in smokers of long term. We're looking at about 10 to 11 million Americans that are affected by this. Hopefully it'll get better as smoking, the incidence of smoking in our population decreases. At least in the American population. Other parts of the world, smoking is still very, very prevalent in their populations. So this is the fourth leading cause of death in the U.S. More than 100,000 deaths annually are due to COPD. Now there's also a genetic form of this, which we'll cover as well. So it's not all smoking, and so there are people that have never smoked a cigarette in their life and have been really not even exposed to secondhand smoke that suffer from COPD. So much like asthma, this is going to be an inflammatory disease. And so this chronic irritation that's occurring in the airway is causing inflammation, and that inflammation ends up resulting in a fibrosis of the bronchial wall. So we get scarring of the bronchial wall long term is what occurs. So we have these hypertrophied mucus glands That's one problem that we're going to have. And so if we look over here in this slide on the right-hand side, we'll have lots of mucus. You can see some mucus production over here, but lots of mucus production in this glandular area. So again, much like we saw in asthma, we get excess mucus that's produced. Now, one of the problems is we have undergone metaplasia over here. So if you notice, this is a bronchiolar wall, which should be our pseudostratified ciliated columnar epithelium, but it's not. It's actually it's stratified squamous epithelium because of that chronic irritation. So that extra mucus that you have just sits there. It's not able to move that orally and be swallowed like it normally would be in healthy individuals. So that's going to end up with significant obstructed airflow that's occurring. We also have loss of so downstream. So once you get to the alveolus, we'll lose our alveolar tissue, particularly in emphysema. So the surface area of the lung has actually been diminished significantly as well, and so we can't exchange gas anywhere near as well. And then finally, a very important one is the loss of the integrity of the lung fibers. And so we'll see things like airway collapse as we're trying to inhale, and we can't get air in very easily because that airway collapses because that negative pressure in there allows that collapse to occur. And then we'll also see obstructed exhalation. So we're collapsing. We got to be very careful we don't collapse from that extra pressure that's being produced during our exhalation that's happening. And so we'll have that going on as well as air trapping that's occurring. And so up here we're looking at this thickened bronchiolar wall. So we have lots of mucus glands in here, lots of mucus being produced and excreted. And then here we're actually seeing the desquamation of our epithelial lining in this case, which has again changed form. It's metaplastic, stratified squamous epithelium rather than the pseudostratified ciliated epithelium that we would normally see in a patient. So we said there's really two different things that are going on in COPD. One is emphysema and one is bronchitis. And I think a nice way now, I want to set this up in advance and say that it's extremely rare, if not impossible, to have only emphysema or only bronchitis. Typically, we see both of those at the same time. So COPD is going to have a combination of emphysema and bronchitis in patients. However, one will be predominant. And so if emphysema is predominant in these patients, we actually call them pink puffers. And if bronchitis is prevalent in patients, we call those patients blue bloaters, because that's typically what we see clinically in these patients. And so what we see in pink puffers, one of the hallmarks of them is pursed lip exhalation. And what's trying to happen is, or what the patients are trying to do is increase the resistance during exhalation because lungs want to collapse when we have that increase in intrathoracic pressure, which is resulting in our exhalation. And so these patients use their accessory muscles to breathe, and they use a lot of energy because of that. And so we need to increase our respiration rate and our tidal volumes just to maintain oxygen levels in these patients. So they have a lot of what we've called dyspnea, which is an increase in ventilation effort. So they don't breathe normally. It's interesting for me when I'm out running and I start running really hard and I start exhaling hard and inhaling hard. I noticed after learning about this, I noticed that I actually purse my lips when I exhale, not because I have emphysema, but because during that exercise, and you may notice it on yourself, pay attention to this next time you exercise, you tend to purse your lips as you exhale because you have such a forceful exhalation that even healthy lungs can collapse to some extent. And so again, that exhalation exertion is very high in these pink puffers. Blue bloaters, on the other hand, which is usually, or I should say bronchitis, predominates in these patients. They can't increase their ventilation enough, their respiration enough, external respiration enough to maintain oxygen levels, so they become hypoxemic. And so they result in cyanosis. So that's why you get the term blue bloaters, where pink puffers do have enough oxygen, and so they maintain their pink coloration in their blood, or in their skin, I should say. And so we'll see cyanosis and polycythemia. So we'll have an excess in erythropoietin production in these patients from their kidneys, synthesizing more hemoglobin and red cells. So we'll end up having a high hematocrit, high hemoglobin in these patients. We also see heart problems with these blue bloaters, because now we have this inflammatory response, and fibrosis that's occurring in the lungs is increasing resistance to flow through the lungs. And so we call this cor, which is coronary for heart, pulmonale, which is lung. So cor pulmonale is when we see a right-sided heart failure that is secondary to our pulmonary hypertension, and the pulmonary hypertension is due to the fibrosis of the lungs, making it harder for the heart to pump. So we have an increase in resistance through our pulmonary circuit. So what is emphysema? So this is the pink puffer one that we're going to talk about. And this is where we have actually an enlargement of our alveolar. So let's take a look at down here in this histologic diagram. And so this would be kind of normal alveolar spaces down in the right-hand corner. So we haven't had a lot of abnormality there yet. But look at this. Here's a big area. We've had a lot of destruction of the alveolar septi up in this area. A lot of destruction over here in this area. Lots of destruction over in this area. We've got some even up over in this area. So this is emphysema. And with emphysema, we lose that elastic recoil that's occurring. So we just have this thin wall, but we don't have enough of them, right? So here we have lots of septum, lots of elastic tissue, and so we have that elastic recoil that occurs, allowing lungs to exhale. So we breathe in, and we typically exhale passively. Well, these patients can't exhale passively because they don't have that elasticity that's occurring. And so we lose the elastic recoil. We have increased compliance, which means it's really easy to breathe in, but it's very difficult to breathe out, and thus we see in those patients that pursed-lipped breathing and excessive use of accessory muscles of exhalation, because we're trying to get air out, because it's hard for us to do that, which is normally an easy thing for us. We normally have to work to get air in, and air exhales with elastic recoil very, very easily. In these patients, it does not do that. In this case, it's not always due to smoking, and so emphysema is one form of COPD that there's actually a genetic predisposition to that, and so there's a protease inhibitor. It's called elastase. Elastase is an enzyme that digests the elastic connective tissue in the body, and so specifically in the lung is where we're looking at this point. So there's a protease called elastase that will be secreted by the neutrophils in the alveoli. So if you have an inflammatory response, which is why smoking can result in emphysema, we have this inflammatory response, we get increase in neutrophil numbers, and they start releasing their proteases, and the one that we're worried about in this case is elastase. So it's going to start digesting the lung tissue, so the elastic tissue in the alveolar septi. Normally, we have what's called an alpha-1 protease inhibitor. And that alpha-1 protease inhibitor inactivates the proteases, the elastases, before it can damage the alveoli. So we have a controlling mechanism in our lung that prevents, because we all have, we're all inhaling irritants constantly every day, and we all have inflammatory cells that are coming up in small numbers, and again, that's preventing permanent damage to our lungs, even though we can have an inflammatory response and get rid of the offending irritant. Some patients have a genetic defect in their alpha-1 protease inhibitor, excuse me. And that means that now even small quantities of neutrophils coming in start digesting the elastic membranes in the lung. And uh, over time we have an increase in damage to the elastic tissue in the septi. Uh, and also, as inflammation gets greater, so we see it in smokers, inflammation will actually cause inhibition of the alpha-1 protease inhibitor, allowing the elastase to digest the tissue in the lungs. And so here's a diagram. So here we'll have smoking. It will be a problem, okay, smoking, and that's the biggest one. Smoking is going to cause inflammation, and it also is going to decrease our alpha-1 antitrypsin activity, which is the elastase inhibitor in that case. And so over here, we'll come back up here. So up here we have the inflammatory cells. So our neutrophils primarily are going to be releasing elastase. Elastase is also going to inhibit normally elastase is inhibited by our alpha-1 antitrypsin. However, if we get excessive quantities of that, we're going to inhibit the antitrypsin itself. And so both of those end up right here at this place. If you have an inherited alpha-1 antitrypsin problem, you can actually jump right down to here. And so our normal inflammation that's going on actually becomes a problem in these particular patients. But the net effect is down here, destruction of the elastic fibers in the lung, and that's what causes emphysema. So emphysema has different types, pathologic or pathophysiologic types, central acinar, panacinar, and paraseptal or bullous emphysema. And century acinar, the one down here, again, look at here's normal, so we have that grape-like cluster, and then we're losing some of those grapes basically here and losing our surface area. And so in central acinar emphysema, it begins in the kind of in the respiratory bronchioles and spreads to the periphery, spreads to the alveolus. It's also termed centrilobular emphysema as well as central acinar. So centrilobular is another term for that. And it's associated with long-standing cigarette smoking, although it can also occur with chronic bronchitis because of that as well, and primarily involves the upper half of the lungs. That's typically where we'll see our central acinar. In panacinar emphysema, we've destroyed the entire alveolus. So if you notice now, we've lost that grape-like cluster altogether. So not just primarily up here, proximal to the alveolus, in addition to the alveolus, but now we've lost all of this. So that's panacinar. Excuse me. It's usually prominent in the lower half of the lungs, and it's generally observed in patients with the homozygous alpha-1 antitrypsin deficiency, so that genetic deficiency in our protection of the elastase. In people who smoke, you'll get focal panacinar emphysema at the lung bases, and that may also accompany the central acinar. So you see both of those in smokers. And finally, we have our paraseptal emphysema, which is also known as distal acinar emphysema, and it preferentially involves the distal airway structures, different distal airway structures, alveolar ducts and alveolar sacs. So this process is typically localized around the septa of the lung or pleura, although airway frequently is preserved. The apical bulla may lead to spontaneous pneumothorax, and so that's where we have these large bulla that occur. So you notice these are just, basically destroyed all of the lung parenchyma here at this point, and they may rupture and open. And when that happens, you get a spontaneous pneumothorax. And I've seen that actually in animals where they'll get a bullous emphysema, particularly in cattle. And they get that from coughing so hard in their particular case that they just destroy the alveolus and get a bullous emphysema. And I've actually seen it in animals where there's so much air that's leaked around into the pleural space, and it gets absorbed up into the skin region, and you actually have like this crackly gas underneath the skin that was due. But again, that's in cattle, not in people. Anyway, so typically these giant bulla are produced in this area, so that's why we call it bullous emphysema, or paraseptal is, I think, what your book calls it. And occasionally these things can cause severe compression of adjacent lung tissue as well as they increase in pressure in that area. So that's really, I guess, kind of the worst, if you would, the worst case scenario of emphysema is this paraseptal or bullous emphysema. So here's a picture of some lungs showing the centrilobular emphysema that's characteristic of smoking that we just described. And one thing I want to show you is you can see that dark material here and here and here and here all throughout the lung, and that's due to cigarette smoking. And so we have these enlarged things with these heavily black carbon deposits, if you would, that are going through there. So this shows, again, destroyed area there, destroyed area there, destroyed area there, and again, typically on the apical portion of the lung. So let's see, what do we see in these patients that have emphysema. And again, one of the hallmarks to this is they have a hard time in expiration, because as they increase thoracic pressure, forcing air out of the chest cavity, it causes those emphysema spots in the lung to collapse. And now we can't get the air out at that point. And so we need to try to keep our pressure up in our lungs. In other words, as we're exhaling, we want to keep the lungs inflated. And so these patients use pursed-lipped breathing. So they'll purse their lips as they exhale typically. So I've seen this all the time. If you go out, you'll see people with oxygen, and they may just be sitting there, and they walk a little ways, they sit down, and all of a sudden they have to their respiratory rates up because of the exertion that they've had. And you watch them, and they do this. I mean, it's amazing. They just breathe in, purse their lips, and breathe out, trying to keep their lungs inflated, and because of that, they also use their accessory muscles tremendously to breathe. And so, due to this respiratory exertion, which again is pursed-lipped exhalation, you'll see the thorax is going to change in size. So we'll talk about that as well in a second. So we have very little coughing that's going to occur in these, because again, that's the coughing will be due more to the bronchitis portion that these people have. They'll lean forward to breathe, again, trying to make it easier for them. They'll get that barrel chest, which is what I was referring to here, and that's because of the accessory muscles that are working very hard. We're trying to keep those lungs inflated as they go through there. We'll get digital clubbing, which is actually fibrosis of the nail bed from hypoxemia. So I think those of you that are taking Nursing 202 are taught about digital clubbing due to hypoxemia or poor perfusion of the nail bed. And definitely dyspnea on exertion. So they'll, as the lungs become worse and worse, they have to breathe heavily when they even simply walk down the hallway. So let's look a little further into this chest wall abnormality. And so normally, we'll go to the normal patient over here. What we're going to do is look at the AP, so anterior to posterior diameter versus our transverse diameter. And most of us, if we're normal chested, we'll have an AP diameter of 1 to 2 of the transverse, so 1 to 2. So if you take an MRI section, for example, you can actually measure this very easily. And you could also measure in the patient if you had the need to do that. In these barrel-chested patients, you'll reverse that. So look at this, we're actually double the AP diameter compared to the transverse diameter. So we have a 2 to 1 relationship at that point. And so it appears this way in this diagram. You see a normal thin chest. It's wider than it is deep. Where here now we have a deeper than wide. And you can really see it's really apparent in this particular cadaver. We've got this huge chest, very, very large chest that actually drops down to the abdominal region. And so there's our chest wall cross-section abnormality. Now, switching gears, we'll look at chronic bronchitis. So these are what we call the blue boaters. Blue bloaters. I got boating on my mind, I guess. It must be spring. At any rate, these are typically patients that have had a lot of inflammatory response or inflammation in the small bronchi and bronchioles. So we'll get this increase in mucus secretion, so a mucus hypersecretion. We'll have a lot of inflammatory cells that have infiltrated that area. And again, we've got metaplasia of the normal pseudostratified columnar epithelium. The ciliated columnar epithelium becomes replaced with our squamous epithelium. And because of this, the excess mucus that we have and the fact that we can't actually move it orally, that we have coughing. So that's really the primary diagnostic criteria that we have is a productive cough for not just for a short period of time, but a productive cough for 3 consecutive months in at least 2 consecutive years. So again, this is chronic bronchitis, not acute bronchitis that probably all of us have had acute bronchitis at some point due to an infectious disease. These are called blue bloaters, typically because the patients are bloated, if you would. So we have, because of that cor pulmonale that we get, the right-sided heart failure, we end up with usually very commonly we get ascites, or here's an ascites in this particular individual. It almost looks like the way he's sitting there with his pursed lips that he could have some emphysema as well. But I know he's probably got cor pulmonale going along because of this edema that's going on from right-hearted failure. So this is the backward effect of right-hearted failure as your left heart is pumping more blood than your right heart can receive. Chronic cough. Shortness of breath on exertion, so very much the same way that we see with emphysema. Increase in sputum, so again we get increased mucus production that's going on through that. And then as we continue to have trouble with our gas exchange, we start turning blue, so cyanosis. So later in the disease they'll start becoming blue, which is why that name blue comes in, and that excess body fluids is why we call them blue bloaters. So what are the consequences of chronic obstructive pulmonary disease? Well, maybe go down to the bottom and look down here. Guess what? Hypoxia and hypercapnia, all because we have inability to move gases in between the membranes, and all of that is derived from our inability to exhale. So we can't get as much air out. We can get air in for the most part, but have trouble getting air out. So let's go back to our physiology. If we remember, we've got 2 areas in our body that have chemoreceptors that sense respiratory gases. One is in our central chemoreceptors in our medulla, and the other are the peripheral chemoreceptors in the aortic arch and the carotid bodies. And so the first question I have here is which step in this flowchart will cause the central chemoreceptors to increase respiration? And that would be our hypercapnia. So we in the brain stem, we sense our carbon dioxide level, well, truly pH level, but we call it carbon dioxide level. Where in the periphery, we sense our oxygen levels. Now, we have to realize in these particular patients, as oxygen levels drop and CO2 levels become high, the body kind of adapts and adjusts to that. And so normally, we'll see oxygen start driving our respiration when our arterial PO2 gets to be 60 millimeters of mercury or less. So once we get down to that level, which usually corresponds to a pulse oximetry, or say an oxygen saturation, hemoglobin saturation level of around 89% roughly for patients. And so because they're low constantly, that oxygen's driving that, and they've just adapted to this high CO2, low blood pH that's just normal to them. And so if they come in and the first thing you want to do, you see that the oxygen saturations are super low. So you think, oh, they need oxygen, and so you throw oxygen on these patients. You get that oxygen saturation up, so the arterial partial pressure of oxygen goes up to the point where it stops driving respiration. These patients actually stop breathing because they're just used to high CO2 levels, and CO2 is not driving that respiration. So we really have to be careful in this particular population of patients putting oxygen on them really suddenly if they're not used to that. So I'm very fortunate that most of my patients didn't have COPD because for the most part my patients don't smoke, and so we see very, very low incidences of lung cancer and really no incidences of COPD due to smoking. So most of the lung issues that I would see in animals were because of infectious agents or toxins. So this animal isn't really smoking, although it kind of appears like it is. So let's move on to the treatment of COPD. And number one is stop smoking. Stop smoking. Filter the allergens that are in the air. Avoid exposure to known irritants. I mean, that goes without saying. Just get rid of the exposure to what's going on. Depending, I mean, at a certain point, the emphysema particularly, you're not going to reverse that damage, but at least you can stop the damage from getting worse. Then we also we'll start using drug therapy. And so we're going to want to open the airways. So we want bronchodilation, and we want anti-inflammatory effects. We want to get rid of that inflammation that occurs. And so these treatments are going to include both asthma and COPD. So that's why I say reduce environmental exposures. We'll filter allergens and get rid of irritants. Well, that is asthma we're really talking about at that point. And smoking is primarily COPD, but we can trigger asthma with smoking as well. So we have two categories. I said we want bronchodilation and we want anti-inflammatories. Fortunately, we've been through some of these already. So our bronchodilators that we use, the most common form are sympathomimetics. So our beta agonist is what we use. That is the most commonly prescribed drug for our obstructive pulmonary disorders. But there's a couple others that we use. One are the methylxanthines, which we'll describe. They're similar to caffeine type of drugs. And the others are anticholinergics, so they're going to negate that effect of the overactive vagal nerve. So we're going to have anti-muscarinic effects in the lungs, leading to smooth muscle relaxation and bronchodilation. As far as the anti-inflammatories, we're going to use primarily inhaled steroids, glucocorticoids. Again, we don't want all the systemic effects of glucocorticoids. Kind of the same with bronchodilators. We're going to inhale a lot of these. And the anticholinergics, so we don't have systemic effects, or we can minimize, probably would be a better way to put it, the systemic effects, and we just have local effects as to what we're looking at. And then we've got a couple of relatively new mast cell stabilizers have been out for a long time, but we have leukotriene receptor antagonists, which are relatively new. So let's kind of just jump through these. We'll take a look at each individual one. I won't spend a lot of time because we've already been through most of the pharmacology of sympathomimetics. So what we're going to look at here is albuterol and terbutaline. Those are the ones that are most commonly used for COPD and asthma, but particularly asthma. You'll even use these in cases of severe influenza, pneumonia, those kind of things where we have a lot of inflammation going on in the lungs, and we want to bronchodilate to get air in and out, so we have difficulty breathing. So up here we have albuterol inhaler. And this is the one I mean, I told you about the hockey, the exercise-induced asthma that I would have as a hockey coach with my players. And typically, I'm trying to think if anybody had an inhaler besides albuterol, and I can't remember over the years ever having anything but albuterol in my pockets. In fact, it was kind of funny because during a game, I'd have somebody coming off the ice having this asthma attack, and they want their inhaler, and I'd be pulling them out of my pockets, and there was, one after another after another. I couldn't find the right name. I just finally said, here, just use whichever one because they're all the same thing. And so again, it's the most commonly prescribed drug for exercise-induced asthma and asthma in general. Over here we have terbutaline. That'd be another form. This would be if we want to have a systemic form, although we can also use it in nebulizers and those types of things. So it does come as an inhalant form, but we can also use it as a oral tablet. And then isoproterenol is another one that is used, and that'll be used oftentimes. It's a non-selective beta agonist, so both beta 1 and beta 2, and it's available oftentimes used in pediatrics if we need bronchodilation in pediatric cases. So albuterol, terbutaline, these are beta 2 selective. Therefore, they're going to dilate the bronchioles. Excuse me. We typically inhale those again, so we're going to have direct effect directly down there in the bronchioles. And so we're going to decrease the dose that we need. We're going to minimize the systemic side effects that we get from taking this, and get mostly a local effect from it. As I set up for terbutaline and isoproterenol, we can use oral or injectable forms of this if a patient can't inhale. Just realize that again, you're going to distribute throughout the body, and everywhere we have beta 2 receptors, we're going to be activating those. The other thing we have with these is a very short half-life. So, I mean, that's good and bad. It means that you can relapse if you're having an attack, but it also means that we're going to get rid of it fast in case you're having some side effects that you don't enjoy, like rapid heart rates and increase in peripheral resistance and nausea and those kind of things, the sympathetic overload type of adverse effects. And so here they are, adverse effects: hypertension, vasoconstriction, cardiac arrhythmias, sweating, GI upset. All of these are sympathetic responses. And it's, again, we're trying to minimize that if we're inhaling it, but we will absorb this drug through the lungs into the systemic circulation as well. Methylxanthines, theophylline used to be a very, very commonly prescribed medication for bronchodilation with asthmatics. Not used as commonly anymore now that we've got other medications with less adverse reactions or adverse effects. Aminophylline is an injectable form of the methylxanthine. So over here we have a bottle of theophylline. Over here we have an injectable form of aminophylline. And then just strictly caffeine. Caffeine is actually a bronchodilator. It's a mild bronchodilator. It's not as strong as the other methylxanthines, but it's a mild, and in fact, there's very strong evidence in the literature that shows that drinking coffee before athletic events actually increases performance slightly. It's certainly not it won't make me into a world-class athlete or anything like that. Believe me, I try with caffeine. Lots of coffee. And I still can't beat Usain Bolt in the 100-meter dash. But so how does this work? Well, we think it's interesting. We think of caffeine as a stimulant, and methylxanthines are stimulants. They're central nervous stimulants. In fact, in chocolate, we have caffeine in chocolate, but there's even a more potent one in dark chocolate called theobromine. Theobromine is the thing in dark chocolate that if you give dark chocolate to kids, they become hyperactive. So both the caffeine and the theobromine are acting, but primarily theobromine. And that's the reason you shouldn't feed lots of chocolate to your dogs. Again, you have central nervous system stimulation and adverse effects because of that. So we're not talking in the central nervous system. We're actually talking in the periphery. And the way it works And here I say it directly affects the smooth muscles by modulating calcium. So let's get a little bit more in depth on that. And so the likely way it works is it antagonizes a receptor called the adenosine receptors, which are competitive non-selective phosphodiesterase inhibitors. That's a mouthful, isn't it? So again, their adenosine receptors are competitive phosphodiesterase inhibitors, and it's going to raise intracellular cyclic AMP, activate phosphokinase A, and start increasing calcium concentration. I'm sorry, diminish calcium concentration. So we get a drop in calcium concentration in the muscle. Uh, some other things here. Let's see. Yeah, and also has some effects on tumor necrosis factor and leukotriene synthesis. So we can actually reduce some inflammation. And so if we antagonize these adenosine receptors, we can get smooth muscle relaxation. Unfortunately, there's also these receptors in the heart, and so not only are we going to have CNS effects, but we have cardiac effects as well in these patients. So the adenosine, there's actually three subtypes, A1, A2, and A3, and if we antagonize those, we cause different effects in the heart than in the smooth muscle of the bronchiole. So bronchial asthma, COPD used to be very commonly used. Now it's not as common because we have a very narrow therapeutic margin, again, a therapeutic window, 10 to 20 micrograms per milliliter of blood. So we need to stay within that. If we get above that, we're overstimulating. We get GI upset, nausea, CNS effects, irritability, seizures, even brain damage, and we have our cardiac effects. We start seeing tachycardia in these particular patients. So I'll just show you this and what's going on with this. This is kind of interesting. It's an aside. When my daughters were in high school, I helped them with their honors science projects, and my oldest daughter, who is now actually a chemistry graduate and working in the biopharmaceutical industry. But she wanted to look at the effect of caffeine, and it was really funny. I'll be brief with this. Let me just kind of give you a laydown of what you're looking at. This is a pharmacologic tissue bath, and so in here, this little test tube here is filled with worm ringer solution, basically. So it's a solution allowing worm tissue to live for a long, long time. Outside this area is a cylinder full of warm water that floats through. So we're pumping that water through this cylinder, keeping this warm, allowing the tissue to stay alive. We've got oxygen bubbling. I don't know if we can see. Yeah, well, there's bubbles on the side of the little test tube there, if you would. So we're actually bubbling oxygen through. So this right here is a worm crop. So I went and bought night crawlers for her, and she actually soaked them in ethanol, narcotized them, then dissected out the part of the GI tract called the crop, which is a very large smooth muscle organ. And then we put a string on here, basically, as some suture, and tied it down and anchored it here. And then it goes up and out that cylinder, and you can't see on the top, there's actually a force transducer sitting up here. So it's just like what you guys did in your muscle lab, the frog muscle lab in physiology. And so this muscle has spontaneous movement, and that's what we're seeing right here. Okay, as we're going up and down and up. So these are normal peristaltic contractions that is occurring through there. And we get to this point. This is where my daughter put her caffeine in, and she dropped the caffeine in, and notice instantly we started seeing this drop in amplitude. So it was relaxing. It even started slowing down here. Look at how fast the waveforms are being produced here and how much slower, about half the speed. So it inhibited that smooth muscle. And it was really funny because it was the opposite effect that my daughter thought would happen. And I'll never forget, we decided we're going to dose it really high for the first experiment just to see what would happen. And she threw the caffeine in there, and the muscle stopped moving. And she said, "Oh no, Dad, I killed it." And I said, "Don't worry about it, And so we flushed that out and put in a fresh batch of ringers. and within a few minutes it was back to moving again. I said, you didn't kill it, you just stopped it from moving because of the caffeine. And that was the opposite effect of what that she thought would happen, because she thought of caffeine as a stimulant, and it is a central nervous system stimulant. But here's a great example of how caffeine is actually a smooth muscle relaxing agent. And so caffeine is a methylxanthine, so this is it works the same way for our theobromine and I'm sorry, our theophylline and aminophylline. Okay, we have anticholinergic bronchodilators. So now we're going to be blocking the vagal tone. So these are muscarinic antagonists, is basically what these are. And ipratropium is Atrovent. That's this inhaler right up here. And so again, it's going to be breathed in. It's going to block the muscarinic receptors on the bronchiolar smooth muscle, allowing the sympathetic activity to overtake the parasympathetic activity. Typically, we use this this isn't a first-line therapy. We use anticholinergics either in addition to our sympathomimetics, albuterol, terbutaline, those kind of things, or if patients can't tolerate those. And so we can switch you to an anti-muscarinic rather than a sympathomimetic. It's a little slower onset of action. It takes about 15 minutes, and it's got a little longer duration. So again, that's good and bad depending on what you're looking for as far as adverse effects going. So we'll have a peak effect in about an hour or two, and we'll have really a long duration of action, about 3 or 4 hours. So we'll actually kind of prevent any relapses, but we'll also have longer adverse effects with patients on this. And these are just going to be cholinergic adverse effects that we went through in that unit. Dizziness, headache, fatigue, nervousness, dry mouth, you get a sore throat, heart palpitations, urinary retention. So again, it's either used in place of sympathomimetics, but oftentimes it's used in addition to albuterol. So now you're hitting both sides. You're blocking the parasympathetic response, and you're activating the sympathetic response in cases that are that one or the other is just not strong enough to take care of. Our next category is anti-inflammatory. So the first category was attacking the smooth muscle, causing bronchodilation. Now we're going to try to attack the inflammatory response and minimize that as much as possible. And the most common thing used for anti-inflammatories, well, I shouldn't say the most common thing used, but one of the most common inhalant anti-inflammatories are the glucocorticoids. And again, we want to inhale these glucocorticoids to minimize the adverse effects and minimize the systemic effects, and just get a local anti-inflammatory effect in the airways itself. The two that I'd like you to be familiar with is beclomethasone, okay, or Vanseril. So this is beclomethasone here. And the other is budesonide. Pulmicort would be another, but both of these are glucocorticoids. So if you remember, glucocorticoids act above our prostaglandin cascade, and so it prevents the production of arachidonic acid. And so because of that, we're going to block both our prostaglandin synthesis and our leukotriene synthesis. And so we're blocking that whole arachidonic cascade, not just part of it. So with these, we'll see an anti-inflammatory effect. We'll be blocking all of those. We'll get a drop in swelling, and it actually will also enhance our beta receptor activity. So these will make your albuterol work better than before. And so it's again very common to see patients that are, if they're refractory to albuterol therapy alone, we may put them on a glucocorticoid in addition to the albuterol for that. It's indicated for asthma. It can also be used for it can be used for any inflammatory thing. We want to be careful with infectious inflammation, though. We can use albuterol without fear of affecting our immune system, but here we're going to have immune suppression in the lungs. And so we want to be careful. We wouldn't want to use this for infectious disease for the most part. And these are actually very well tolerated. So this is one where we can have the effect and have a local effect, and we don't really have much beyond that. And so patients complain of sore throat, hoarseness, coughing, dry mouth, those types of things. The one thing you can see is because of that immune suppression, local immune suppression, you can start seeing upper respiratory tract fungal infections, so in the pharynx and larynx. We're breathing in fungal spores all the time, and they can take up, and if our immune system doesn't get rid of it, we'll end up with a fungal infection. But that's not very common, so it's for the most part, they're well tolerated. We have this really interesting one. These are mast cell stabilizers. So they are going to prevent mast cell activation and release of histamine, and just as importantly, are leukotrienes, or the slow reactive substance of anaphylaxis. The cromolyn is the generic name for this, so Intal, cromolyn sodium Intal. These are actually inhaled. These are powders that you inhale. So the other forms so far that we've talked about are a liquid aerosol, much like you get in most spray cans. But this is actually a powder that's put in there, and it breaks up the powder in a very fine dust. In fact, there's a lot of these inhalers have an incredible amount of engineering that go into them, because the particle size has to be just perfect. If the particle sizes are too big, as you inhale these drugs, they just end up in the back of the throat and never make it down to the lungs. If the particles are too small, they breathe in and you just breathe them right out again. So there's this really perfect particle size that is needed for us to get those down to where it belongs. So it's going to prevent, again, histamine release, leukotriene release, and it's indicated for asthma, and exercise-induced asthma are the indications. But so basically, asthma is primarily what we're going to use this for. Very, very, very few adverse effects with cromolyn sodium. And then finally, our newest category are leukotriene receptor antagonists. It's really kind of over the years, this is one lecture that a lot of students, it would be very rare in a class to not have students that have asthma. And so a lot of the students are already familiar with some of these drugs, and a significant number of students, well, are on albuterol, but also a significant number are on these leukotriene receptor antagonists. And so you'll see these advertised on TV as well. So we have Montelukast, Singulair, that's this one over here, and Zarfirlukast, Zarfirlukast, Accolate, which is this one here. Those are the two that I'd like you to be familiar with for the purpose of this course. These are receptor antagonists, so leukotriene receptor antagonists. So with cromolyn sodium, it prevented leukotrienes from being released. Here they're being released, but we're preventing them from acting on the respiratory smooth muscle. And so if we can block that leukotriene, so again, leukotrienes are that the slow reacting substance of anaphylaxis. Leukotrienes have a great effect on the bronchioles, resulting in bronchoconstriction. And if we block that bronchoconstriction, we'll end up with bronchodilation. So again, chronic asthma, people actually take these for allergies as well. So allergic rhinitis would be another one. These are preventative drugs, and so they're not indicated for acute asthma attacks. So if patients are on these, typically they'll also be prescribed an inhaler as well for the acute attacks that could occur. There are some adverse reactions with these, so some patients complain of GI distress, and then there's some central nervous system side effects as well, so hallucinations, dizziness, agitation, those types of things could be involved when you're on these medications. So that is the summary of our respiratory diseases. Looking at this picture, I would suggest please don't try this at home. It does not look safe at all. And I'm hoping she just had that in her mouth and wasn't actually exhaling that out of her lungs. At any rate, bring questions again to class, and that would be the summary of our respiratory system diseases.